Serotonin syndrome is actually defined as a group of symptoms that may occur with the use of certain serotonergic medications, like antidepressants, like selective serotonin reuptake inhibitors, selective norepinephrine reuptake inhibitors, tricyclic antidepressants, also known as CPAN, monoamine oxidase inhibitors, known as MAOIs. And serotonin syndrome can occur with other drugs and other dietary supplements or other medications. It doesn't have to be with just antidepressants. Any medication that can increase the serotonin level activity at the central nervous system and also the peripheral nervous system can cause serotonin syndrome. And it is characterized by a triad of potentially life-threatening symptoms, mainly altered mental status. That could be confusion, agitation, anxiety, autonomic instability, like tachycardia, hypotension, and neuromuscular dysfunction, like akathisia, clonus, and muscle rigidity. Those are examples of in developed countries, the incidence of SS is rising as a result of the growing number of in developed countries, the incidence of SS is rising as a result of the growing number of serotonergic drugs available, the increased use of medications in clinical practice, and the diagnostic awareness of the syndrome. Before now, there have been a lot of controversy about the diagnostic awareness of the syndrome. Even the medication used, it's now that we're saying the antidepressant that should be used should be the SSRIs rather than the TCAs. So there's increased use of these medications in clinical practice. And a lot of physicians and pharmacists are aware about the presentation and management of these syndrome, which can actually cause morbidity and mortality in patients. So a number of drugs from different classes, as I said earlier, cause SS, but most important cases are in patients taking multiple serotonergic agents. So depending on their mechanism of action, these are medications or substances that are associated with serotonin syndrome. Those are actually reduced serotonin reuptake of the metabolism. That will cause increase in serotonin level in the brain. And so drugs like antidepressants I mentioned earlier, opioids, tramadol, methadone, pethidine. And for instance, a patient comes to our end and is diagnosed of depression, and the patient had an accident and had to go to orthopedic hospital, and they now prescribed tramadol for pain. So this drug interaction can actually result in serotonin syndrome, and it's important that we know the medications our patients are using. Dextromethorphan can be found in the over-the-counter cough syrup, which is readily available anywhere. So anybody using other serotonergic medications can also cause SS, that's serotonin syndrome. The triptans and the antiemetics as well. For those that increase the serotonin synthesis or release cocaine, there have been cases of patients taking antidepressant like SSRI and also taking cocaine and has resulted in serotonin syndrome. The MDMA, I mentioned the dextromethorphan, the phentermine, another antidepressant, levodopa, and L-tryptophan. We also have the direct serotonin receptor activation. The fentanyl, which is also an opioid, lithium, buspirone, sodium valproate, and also drugs that can actually cause cyclochrome P450 enzyme inhibitors like sertraline, ketoprostatin. So if this medication actually with other drugs that can increase serotonin levels, the possibility of serotonin syndrome occurring is very high. So as I said earlier, it's characterized by three major symptoms: the altered mental status, which is agitation, confusion, anxiety, restlessness, excitement, delirium, in serious cases, coma. Autonomic instability, hypertension, tachycardia, diaphoresis, excessive sweating, hypothermia, increase in fever, nausea, vomiting, diarrhea, hydritis, which is also dilation of the pupil. Neuromuscular abnormalities are tremor, clonus, which is intermittent contraction of the muscles, muscle rigidity, hyperreflexia, that has to do with excessive reflex. For instance, if a particular place like knee is touched, and then the patient, without the patient's ability or something to take to actually raise the leg, once the examiner or the doctor hits the knee, the leg automatically lifts up without, it's just a reflex action to what happened without the patient actually doing that or raising the leg itself. Akathisia is the patient will be restless. The ability to sit in a particular place is very difficult for the patient. It keeps pacing up and down, restless. The person sits down, stamping his feet, or maybe the patient crosses the leg and keeps on crossing and uncrossing the leg. Those are signs of akathisia, and it could be due to serotonin syndrome. Now, the diagnosis, it has to be that, that's why we have to do very thorough medication reconciliation when it comes to knowing the history of the patient's recent and current medication, so that we'll be able to determine whether the patient took any serotonergic medication recently. Secondly, serotonin syndrome does not have any laboratory investigation as of today. It's majorly through clinical investigation. We can't use laboratory investigations to confirm serotonin syndrome. Earlier on, the Stenberg's criteria was actually on for a while, 1991, and we have another one called Untitled criteria, because that one is more specific and sensitive. So it's more preferred to use the Untitled criteria, but some other people still use the Stenberg's too. So that's why I'm going to actually explain both. For the Stenberg's criteria, we have the symptoms. The symptoms I explained earlier: diarrhea that is under autonomic instability, agitation under mental status, and then the hyperreflexia under neuromuscular dysfunction. All the symptoms. Diagnosis for the Stenberg says patients should present with at least 3 of the symptoms, the use of serotonergic medication. Presents with this, and there is no record of the patient. We can't say that's why other criteria is more sensitive and specific, because all these symptoms can actually occur with other diseases or ailments. So a Untitled criteria is much more better to use as for the diagnosis of serotonin toxicity. So the symptoms for Untitled criteria, they group the symptoms of serotonin syndrome into 5 groups. It means that for the first one, the spontaneous clonus, means that if the patient has spontaneous clonus, that means involuntary muscle contraction and relaxation, then with the use of a serotonergic medication or more than one, then you can say the patient has serotonin syndrome. Secondly, if the patient has tremor and hyperreflexia, then the patient with the use of the medication as well has serotonin syndrome. Or if the patient has ocular clonus, that's the involuntary movement of the muscles in the eye, with agitation, the patient has SF. Or if the patient has ocular clonus or with diaphoresis, that's excessive sweating, the patient has SF. So it has to do with all the inducible clonus too, with agitation or diaphoresis. The inducible one is being done by the examiner. For instance, most of the time, those clonus actually happens at the lower limbs. The examiner touches the ankle, and then the leg starts, shaking involuntarily. So that's for invisible clonus. Then hypotonia with temperature greater than 38 degrees centigrade plus ocular clonus or invisible clonus. So as the diagnosis says, the patient presents with at least one of the groups of symptoms with a history of serotonergic medications. Now, we also have to do differential diagnosis because some illnesses, they mimic serotonin syndrome. For instance, sepsis. Sepsis will bring about fever and is part of the symptoms of serotonin syndrome. Sepsis will bring about mental change in the status of the brain. It brings about that. It can also affect the neuromuscular, part of the body. So, but for the sepsis, we can always do a laboratory investigation to be able to rule out that it's not serotonin syndrome. So that's where the differential diagnosis comes in. That's where the laboratory investigation actually comes in. As I said earlier, we should take note, serotonin syndrome, we cannot use laboratory investigation to diagnose it. Neuroleptic malignant syndrome also, the same thing. There's fever, there's altered mental status, there's also autonomic dysfunction. But the difference is that neuroleptic malignant syndrome actually occurs with the use of antipsychotics, and the major thing is the blockage of dopamine. And unlike the serotonin syndrome that is caused by excess serotonin activity in the brain. Another difference is that the neuroleptic malignant syndrome actually has a slow onset of starting, while serotonin syndrome can occur within 6 to 8 hours after taking the medication. Another difference is that serotonin syndrome, on removal of the offending agent or the drug, within 24 to 72 hours, the patient will recover from the syndrome. But for neuroleptic malignant syndrome, if the offending agent is actually removed, it can be on for several weeks that the patient will not have recovered. Another one is anticholinergic toxicity. This also has fever, mental status changes, and also autonomic, and also neuromuscular dysfunction. So these are differential diagnoses we need to watch out before we say that, oh, the patient has serotonin syndrome. And another thing, as I mentioned earlier, is there must be serotonergic drug actually present. So how do we prevent the occurrence of serotonin syndrome? As I mentioned earlier, a lot of pharmacists, physicians are not aware. So we need to be aware of serotonin syndrome. Not only us, the physicians are going to prescribe the medications and the patients themselves. When we dispense these serotonergic medications, we have to educate the patient that in case you experience any of these symptoms, please do not hesitate to come to the hospital immediately. Another thing is, if possible, we should avoid the use of combining serotonergic medications. It might not be the SSRIs alone, as I use an example of tramadol and the SSRIs, examples of sertraline, Zoloft, or paroxetine, Seroxat, and all that. So we should try and avoid it. Pharmacists should check for possible interactions when multiple drug regimens are required. Another thing which is very important and we'll be discussing more is understanding the strategies for switching antidepressants. If you can understand it, because serotonin syndrome has been implicated that most of the time is the use of antidepressant that actually causes it. So we need to understand how to switch the antidepressants. We have switching strategies for antidepressants. There are actually three. We have a direct switch, we have a cross taper, and we have the modified cross taper. For the direct switch, it can be applied if the first drug was used for a short period. Sorry, it should be less than, not greater than 1 week. That's an error on my part. So for less than 1 week, it should be less than 1 week. Then when switching between same class, SSRIs, SNRIs, and TTAs, you can switch. For instance, an example of SSRIs, selective serotonin reuptake inhibitor, paroxetine, sertraline, fluoxetine. So you can switch between sertraline, fluoxetine, pyroxetine, citalopram. But if you want to do direct switch, you can switch from serotonin and SSRIs and TCAs, which are the amitriptyline or very popularly known as tryptozole or imipramine. For direct switch, you can switch. It only has to be within the class. Then what you do is that you stop the old antidepressant and then they start the new one the next day. That's what direct switch is about. For the cross taper, you titrate the new antidepressant to therapeutic dose while old one is being tapered. Let me mention that for the direct switch, yes, we have advantages and we also have disadvantages. For the advantages of the direct switch, there is no washout period. Washout period where you'll be wondering that how will the patient cope if the patient is not on this medication. And the patients can also reach the therapeutic dose because for direct switch, what they do is that the equivalent dose of the old and the new drug is what is prescribed. For instance, if the equivalent dose of sertraline to fluoxetine is 150 milligram of sertraline to 20 milligram of fluoxetine, that's what you actually switch to. You don't need to begin to titrate up. So that's an advantage. But the disadvantage is that the risk of drug interaction is very, very high. Also, withdrawal symptoms of the drug, stopping the medication suddenly is also a disadvantage. So for the cross taper, you can titrate new antidepressant to therapeutic dose while the old one is tapered down. So you keep increasing the new antidepressant to therapeutic dose. Once old antidepressant is stopped, you can only give the normal therapeutic dose of the antidepressant once the old one has been stopped. Of course, it also has advantages. The advantages is that there is no washout period. At the same time, for potentially high-risk patients where taking them off their medications can cause a relapse is an advantage as well. And then withdrawal symptoms will also be reduced. Recurrence of relapse will also be reduced. But of course, it has a disadvantage. Disadvantage is the high risk of drug interaction. That's one. And then sometimes it takes a very long time before you can actually taper off the old antidepressants. So that's another disadvantage of cross taper. For the modified cross taper, you gradually reduce and stop the old antidepressants. Consider a drug-free washout period of over 2 to 4 days. When you want to stop, you begin to reduce the medication. Some say 25% every week. And then after reducing and you stop, you also allow a drug-free period of like 2 to 4 days. And then now start the new antidepressant at the typical starting dose. It also has its advantage, yes. The patient will benefit from having, there will be no withdrawal symptom. And there will be no withdrawal symptom, that's the advantage. But disadvantage is that high-risk patients that can easily relapse, it can affect such patients that will have a washout period. The same thing that while tapering down the old antidepressants, it can take a very, very long time. So with the switching of the understanding of the switching of the antidepressants will help to avoid side effects or even adverse drug reaction like serotonin syndrome. So how do we actually manage serotonin syndrome? We have the mild symptoms, we have the moderate, and we have the severe one. I've mentioned the symptoms, so I might not mention all of them one by one. But to manage them, the first thing is to discontinue the offending agent. We try to stabilize the vital signs. That's the temperature, the blood pressure, and then you also check the pulse rate, whether it's normal. And then for mild agitation, fever, and hypertension, tachycardia, you use benzodiazepines like diazepam and lorazepam. You'll be wondering why there's no medication for, you're saying fever, you should use benzodiazepine. Yes, because in serotonin syndrome, the fever is not actually caused by the normal central thermoregulation. It's actually caused by the overactivity of the muscles. So using antipyretic in serotonin syndrome is out of it. It won't help. So the best thing is how to, a muscle relaxant, to be able to relax the muscles that are overacting. So that's why benzodiazepines are given. And then you observe the patient for over 6 hours. Most times for mild symptoms, the patient does not need admission. The patient can go home and watch how he's actually recovering from the symptoms of serotonin syndrome. For the moderate, all of the symptoms above, plus a temperature that is very high, over 40 degrees centigrade, active bowel, sounds, agitation, hypervigilance, the patient is too alert of what is happening, and then is so sensitive about the environment. So, and that has to do with the altered mental status. Pressure speech. The patient just continues to speak at a very rapid pace and might not even stop at all. And anybody listening will not be able to understand what the patient is actually talking about. Of course, for the treatment is for severe agitation and increased fever. You use the 5-HT antagonist, ciprofloxacin. It actually blocks the 5-HT1 and 5-HT2. A lot of studies have been shown that for case reports and case series, that it has actually helped in resolving so many serotonin syndrome symptoms. And that's why it's being used. Admission to hospitals for cardiac monitoring and observation. For the severe one, dramatic swings in pulse and all that, for severe hypertension and tachycardia, we use esmolol or nitroprusside. Why? You have to use a short half-life drug. For propranolol, it has a long half-life and it can cause hypotension, which can lead to stroke. So you shouldn't use propranolol in in managing serotonin syndrome. Then sedation and paralysis with a non-vaporizing agent. Yes, we need sometimes, if it's so bad that agitation is so high and the patient is uncomfortable, restless, we need to paralyze them because agitation actually can cause a large amount of muscle damage. And muscle damage can actually lead to kidney failure or kidney damage. This is because once a muscle is damaged, it releases a protein called myoglobin. The myoglobin is actually released into the bloodstream. It's actually filtered by the kidney. And once it breaks down into substances in the kidney, those substances, those myoglobin substances, destroy the kidney cells. So we need to avoid that. And so that's why they need to sedate the patient and also use any drug that will paralyze the patient's muscles. So summary of the interventions. The muscle relaxant, as I mentioned earlier, helps control agitation, seizures, and muscle stiffness. The serotonin antagonist, ciprofloxacin, blocks serotonin production. So that will help to drastically reduce the serotonin that's actually causing the symptoms. Oxygen and intravenous fluids for dehydration and fever. Those are severe cases. Maybe that the patient will have to need the oxygen and intravenous fluids. Control of heart rates, high heart rate and blood pressure. Hypotension, you can use epinephrine. For very high fever, intubation, artificial ventilation, medication to paralyze the muscles. I've already explained the reason why they need to paralyze the muscles. So let's look at this case study so that we can understand what we've actually been talking about. BL, a 31-year-old male with medical history of major depressive disorder and post-traumatic stress disorder. The patient was directly switched from sertraline, which is a drug under the SSRI, selective serotonin reuptake, 150 milligram daily, to fluoxetine, 20 milligram daily, another selective serotonin reuptake inhibitor, as a depressive symptoms such as insomnia, withdrawal from others, and mood swings still persist after several weeks of treatment with sertraline 150 milligram. Patient denied use of all substances aside occasional alcohol use. Okay, so 1 to 2 days after direct switch to fluoxetine, his wife reported that the patient suddenly left the house without his shoes on, stared blankly at the wall for an extended period of time, angry outbursts with no response afterwards, muscle twitching and sweating. From the suddenly left the house without his shoes, stared blankly on the wall, that shows altered mental status. And then the muscle twitching, we are talking about the neuromuscular dysfunction, and then sweating, autonomic instability. So fever, 38.5 degrees centigrade, the people being high and the hypertonic, they call for 1 per minute. Also high, blood pressure was 112, what 80 milligram, 80 milligram mercury. So as I asked, what is mild? Mild to moderate, moderate or severe? And secondly, was the switching approach for the antidepressant, was it actually right? So we'll come back to that. So management of the patient was to stop the fluoxetine immediately. And then they started with oral tablets, 2 milligram lorazepam, which is a better lorazepam to probably reduce fever and any of or the switching was given, followed by 1 milligram doses of lorazepam. The symptom of the patient began to resolve within 36 hours, with complete response within 3 days. On follow-up, there was no recurrence. I probably put this here for severe cases, in case that the patient, after you discontinue the offending agent, only mild response within 2 to 3 days. As I mentioned, you can always use ciprofloxacin. Some prescribe 8 milligram CDS for 7 days, or 12 milligram start followed by 8 milligram every 6 hours. IV fluids, 1 to 2. So I want us to go back to the question. What do you think it is? Is it mild, mild to moderate, moderate or severe? If you look at the symptoms, it's more of mild because you have a mild fever, the mental status that was altered, you don't have a temperature that is over 40. And then you don't have a temperature that is over 40, and then the clonus too is not there, just a twitching of the muscles. Then was the switching approach for antidepressant right? Yes, when we talked about the direct switch, because that's what they did here, we said you can switch between the same class of medication. But something was mentioned. We should only switch if it's less than a week or within a short period. But the patient has been on this medication for several weeks and decided to just change the medication. We also have to put in our pharmacokinetics here. Sertraline has a half-life of 26 hours, on the average 22 to 36 hours. And we know that it's established that for complete elimination of the drug in the body system, we need to have 3 to 5 half-lives before it can be completely eliminated. So that means by the time the patient was starting the fluoxetine, some active sertraline was actually still in the body system, which would have caused drug interaction and increase in serotonin that would have led to serotonin syndrome. Of course, we expect that by the time the patient was taking the fluoxetine, the sertraline level would have been reducing and then minimize the risk. Of course, we also know about phenotypic variation among individuals, whether it's a slow metabolizer or something, we can't really determine. So what we do is that when such thing is going to happen about the direct switch, which one is even wrong because for several weeks, but in case it's even less than, we need to tell the patient to watch for different signs, because it has occurred that apart from drug interaction, for a single selective serotonin reuptake inhibitor, serotonin syndrome has actually occurred. There are also cases where for 5 weeks they have discontinued the medication, washout period. By the time they introduce SSRI, the patient actually came down with serotonin syndrome. So can we rechallenge? Because at this point, we have to stop. and this patient is still having mood disorders. So what do we do? As the serotonin syndrome is actually a predictable reaction, the drug can be rechallenged after adequate washout for a long time. Another option is to switch to a drug that has less serotonergic activity. For this one, some of them act on the dopamine and norepinephrine, while metazapine acts on serotonin and noradrenergic receptors. So we look for other options. It might be the TCA, the tricyclic antidepressants, if the patient cannot tolerate the SSRIs. So in conclusion, we should know that serotonin syndrome is not an idiosyncratic drug reaction, but a predictable response to elevated serotonin levels. Antidepressants are frequently implicated in serotonin syndrome, most especially the SSRIs. Symptoms can occur within 6 to 8 hours of drug interaction, initiating or increasing the dosage of serotonergic medication. And also, it can be resolved within 24 to 72 hours once the drug is actually removed. And so because of that, appropriate medical management of serotonin syndrome is generally associated with a favorable prognosis. I want to appreciate everybody for listening tonight, and I want to say thank you so much for listening.
So we want to thank our speaker, Pharmacists, for that great and very educative presentation.
Very beautiful presentation.
The floor is now open for comments, contribution. If you have anything to contribute, you have a question, you can unmute yourself or raise hands, or you can send your questions through text. So, Pharmacist, can you stop sharing your slides so that people can? Okay. You have been enabled to unmute yourself if you have contribution. Can you stop sharing, Pharmacist? Okay. So we welcome contributions, comments from all the participants.
Hello.
Hello, ma'am. Go ahead.
Yeah, my comment is just to say thank you for the lecture. I do not really think I know much about drugs used in psychiatry. I'm really delighted to hear this lecture because it's kind of updating me on things that I have long forgotten. So again, thank you so much. God bless you.
Welcome, ma.
Thank you, ma'am. So we welcome more contributions, more comments. You are free to, you just raise your hand up, then we call you. You are free to make contribution, please. Okay, Pharmacy is Afusat, please, you are called, please. Pharmacy Afusat, Buhari, please. Unmute yourself.
Okay. Good evening. Thank you very much, Ma, for the wonderful presentation. This mine is a question. Is with respect to management of severe SS. You mentioned that we can use esmolol or nitroprusside. I just want to be sure of why the choice of these two. We'll have propranolol and others in the same group.
Okay. Thank you, Pharmacist, for the question. I mentioned earlier that we need to use a drug that has short half-life, because we have part of this symptoms is autonomic instability. So it could go hypo or hyper, and then we need a drug that has short half-life. They've actually done research, evidence-based, that esmolol and nitroprusside is better off. If propranolol is used, it has a very long half-life, and it could lead to hypotension, and that can lead to shock, and we still lose the patient. So that's the reason.
Thank you very much, ma'am.
You're welcome.
Okay, Pharmacist, Dr. Sariam, please, you can unmute yourself and make your contribution, please. Dr. Sariam, unmute yourself and make contribution there. Dr. Sariam, you are free to unmute yourself and make your contribution, please. Dr. Sariam is raising your hands. Okay.
Hello.
Hello, please go ahead.
Okay, just to appreciate the presenter.
Okay, fine.
Thank you.
Yes, and it's actually not an area that most pharmacists would like to go into, but we have a few that are interested in mental health. And so I commend you for your wonderful presentation.
Thank you very much, ma'am.
You're welcome.
We still welcome questions, contributions, comments. So we want to recognize in our midst the presence of our chairman, Dr. Joseph Madu, all the executive committees, all our elders and lecturers, all the participants. You are appreciated and welcome. So we still have room more for contributions, for comments, for Dr. Onilade Kendi.
No.
The day is still young. It is just, the day is still young. So we are free to omit ourselves and make our contributions. So, Dr. Onilade, you talk about the high temperature, is it hyperthermia?
Hyperthermia, yes.
Hyperthermia and the use of ciprofloxacin, not paracetamol or any other analgesic.
Yes, use
Can
of
you explain?
Yes.
Okay.
As I said, the increase in temperature is not due to the normal hypothalamic temperature set point abnormality or central thermoregulation. It's actually due to the overactivity of the muscles. So what we need is a muscle relaxant. If the muscles can relax, the temperature will be able to be reduced. That's why antipyretics have not been used. It's not going to work because it's not due to the normal central thermoregulation. It has to do with the overactivity of the muscles, and that has to do with the neuromuscular dysfunction aspects of the serotonin syndrome. I hope that's clear.
That's okay. Then again, I want you to clarify between the use of antidotes and treatment. What is the difference between using antidote to the toxicity and management? Is there any difference between the two?
Well, with the use of, well, what we will call the antidote is a cyproheptadine, because sincerely, there is no evidence-based or randomized placebo trial that has been done for the management of serotonin syndrome. There's no guideline. But because we have a lot of case reports and case series that have actually used this medication, and they found out that it actually works. The antidote is that the cyproheptadine is an antagonist, the serotonin antagonist. We have the serotonin receptor between 581 and 587, but the cyproheptadine actually blocks 581 and 582, and that's why it works. So we can say that's like an antidote for serotonin syndrome, but no clear-cut guideline for management. But those medications have been used, and so many symptoms have been resolved with the use of those medications.
Thank you. And one last thing for me is about the cyproheptadine. It is a common drug over as we know, in super pets and Gold. Commonly, as a noticed drug, people use it for other things like sleeping pill, like what is called many things. Just a kind of misuse of it. What is your say on this one?
Well, that has to do with us as pharmacists to regulate it. I knew that as far as back as when I was doing internship and I was doing locum in a community pharmacy, they were coming in to buy it for so many different, reasons and all that. So we as pharmacists should be able to regulate that. You can see how important it is in this serotonin syndrome when we misuse and we don't have it available very well, when a patient actually needs it, because as I said, they can cause potentially life-threatening symptoms. For instance, kidney failure, it can occur with this serotonin syndrome. People do die, high increase in blood pressure and all that. So for me, I think we as pharmacists should be able to regulate that and make sure that they are actually used for what, because it's also an antihistamine, it should only be used for what is being prescribed for.
Okay. Dr. Lulujo, please, you are raising your hand. Please, you have the floor. Dr. Lulujo, you have the problem. You can unmute yourself and make a comment. Dr. Lulujo, unmute yourself.
Yes, please. Thank you so much. Thank you so much. Yes, I've unmuted.
Okay, please go ahead.
Can you hear me?
Yes, I can hear you, sir.
Can you hear me?
Yes, sir, I can hear you, sir.
Okay, thank you. Okay, good. Okay, good. I would like to thank Kehinde for that brilliant lecture. I came in the middle of the lecture, and I must tell you, I enjoyed the time. I have been involved in antidepressants way back in 1996 when we launched muclobimide, Ororix. So I was really involved, and it was a refresher course for me as I follow you through the management of SS. Now, you will pardon me because I didn't start with you if my questions have been answered in your earlier presentation. My first question or maybe comment is this: how deep are we involved in the management of patients, such that issues, medication therapy gaps, like the one that you have mentioned in your presentation, could have come up, and that there could have been intervention from the pharmacists. How deep is that? Do we have that hands-on clinical experience in management of patients that can allow us to intervene when we notice gaps of this nature? The second one is that if we are, or even if we are not, do we have something or a medication improvement project that we would like to pursue, which can now be done in collaboration with the psychiatrist, and which this group can look for a way of making sure it happens, so that it can enrich, the participation of pharmacists when it comes to management of depression and other psychiatric illnesses. These are my questions, which I've actually even discussed in advance with the chairman of the group.
Thank you, sir. Up to you.
Yeah, thank you very much, sir. And I'm so glad that my HOD is around, and I also want to appreciate her so much, because without her, I can't be here presenting. It's part of what she has actually, imbibed in us. And I'm sure she will also be able to add that in the person of Mr. Theo Peter, a fellow of the Society of Nigeria. She'll also be part of you that will be ready to answer the questions as well. I believe so. So for the management, we've had cases of, it might not be particular to serotonin syndrome. Another thing I didn't mention is that if it's mild, it can go unnoticed. The patient can actually be experiencing it, and the next thing, it's get resolved. Maybe the patient will like, he or she is not sleeping, and then the big benzodiazepine work. In such cases too, like the case study where I actually, patients stood up and went out without wearing shoes, stares on the wall blankly for a long time. What will come to our mind first is what? Psychosis or schizophrenia. You won't think that it is the side effect of the medication. So, but we have cases like that where we know that side effects of the medication can actually alter the patient's mental state, and we do make interventions and documentation. On improving such, I'm sure we are so much welcome to that we can work in collaboration with the Clinical Pharmacy of Nigeria. So I think it's a welcome idea, sir. So we can always work in collaboration with psychiatry. For me, psychiatry is something that a lot of us do not know. But when it comes to medication, so many things come into play. A patient that attends psychiatric hospital will also attend any of the teaching hospitals, orthopedic hospital, comes to community pharmacy. We need to ask questions about medication reconciliation, what medication the patient is using. And even if not deep, but as for those of us that are at psychiatric hospital, we can as well know a little or more, and that will also help us. I hope I was able to answer the question.
Thank you. I call on Professor Bulla Olaiwola, please, to you have the floor, sir. Prof.
Good evening, all.
Good evening, sir.
Yeah, I appreciate Candy a lot. I actually appreciate her. And I want to say one thing that is going, for her as different from other teaching hospitals that I know. They are like specialists because they are in neuropsychiatric hospitals. So their focus is defined. They concentrate a lot more on that. The problem, as Dr. Lolo has pointed out, that is not making other teaching hospitals, as it were, to be interested in this is because there is little or no specialization in the teaching hospitals with the pharmacists. It's only, University of Nigeria, Nsukka, the Enugu campus, the hospital in Enugu, where we have a semblance of specialization, where you have cardiovascular pharmacists, you have HIV pharmacists, you have other, aspects. The first thing that we need to do, is to encourage specialization. And that will be actually a meeting of CPAN with all HODs of pharmacy. The reason is clear. There will never be a time that you have enough hands in pharmacy. If anything does not prevent it, budget will prevent it. The hospital will complain about, budgetary allocation and, all those bureaucratic problems. That is on one side. We can work towards it, while we are appreciating those that are from specialist, institutions like the neuropsychiatric hospital in Yaba and Abeokuta. Now, I have a question for the presenter. Now, there are issues in depression, challenges with comorbidity, particularly when you have a depressed, hypertensive. When you have a depressed hypertensive, yes, she made good efforts at saying if they have hypertension or if they have hypertension and, prescribing, is this Semlolol, something like that, However, because of the mechanism, the fundamental mechanism by which depression comes, which is, depression of the store of, the monoamines, particularly serotonin or norepinephrine, you know, or even dopamine, all the monoamines. Because of inadequacies of all this, that's where we have depression most of the times. And when you want to, you know, upgrade some of these neurotransmitters, they impinge on the cardiovascular because they are all pressure, you know, substances. So it's usually a challenge. That is one. Another question is, how long, on the average, does a depressed or someone diagnosed with depression, you know, stay in the facility, in the clinic? Yes, there are some grades of mild depression can be treated on ambulatory basis, but when the depression, you know, approaches the one for suicidal tendencies and all those things, the person has to be reined in and hospitalized. Why I'm asking this is because some of these psychotropic drugs take their time, or the brain takes time to accommodate them. It's not like you have a pain or like acute system, acute situations where you have a painkiller and it does its work, working peripherally. The brain has to first accommodate and adjust, and it takes on the average about 10 days, between 10 and 2 weeks, 10 days and 2 weeks. That's why on the average, people will, with psychiatric problems or, you know, CNS problems, they hardly spend less than 3 weeks, you know, in the facility. I want candidate to do some mini study on this at their facility to look at the average time, you know, that a patient spends. You know, from our experience at the OAU THC, you know, we have seen that the average time, you know, is about three weeks, cannot be less, because the brain starts adaptation at about 10 days, and for the first 10 days, you know, you will be you cannot allow the patient to be out of the facility, particularly if it is severe depression. It's been beautiful listening to her, and I thank all of you. Good evening.
Thank you, sir. So, Dr. Onyinade, do you have anything to say to that? Or do you call another? Dr. Onyinade?
Yeah, thank you very much, sir. For the drug, it is actually a complex issue, really, because most times, even the antidepressant, it takes sometimes as high as 6 weeks before you can actually start seeing the effectiveness. It takes a long time. Studies have even shown that sometimes it takes months before it can actually, and then the complexity of some of them even causing, some of them having suicidal risk. A patient coming in for major depression, and then we are given the medication, and then at that point, or we heard that the patient wanted to commit suicide, came up, and then we still have to give the SSRI. So it's a complex issue. It actually is a complex issue. But another thing, management of this patient is not only by drug. The psychologists come in too, and it can. The cognitive behavioral therapy has also gone a long way. Some even don't use the medication, some just use the psychologist sessions, and they are fine. So, issue, they say if they have to come into our place, you can stay more than 3 weeks when on admission, especially if you know that the patient is at high risk for suicide. And of course, as you mentioned, the complexity of using the medications with antihypertensives and all that, we have work to do as pharmacists. As it was mentioned that specialization is very important. We can't know everything. And if we pharmacists can start specializing, that will help us. And like this kind of clinical meeting that we have to get in, we're able to make us learn and understand and apply it whenever we go back to our institution. Thank you.
Thank you. I call on Dr. Ademola Suleiman to make his own contribution. You have the floor. Dr. Ademola Suleiman.
Good morning, everyone. I am already on Saturday here.
You're welcome.
So my contribution and the question, but before I made my contribution, let me also thank my sister, my colleague at Yaba Psychiatric, Kendi, for the wonderful presentation you have made. Having listened to my senior colleague, Dr. Loluojo, and my lecturer, Professor Bola Laiwola, I want to write on their comments that the reward for good work is another work. And I want to make a suggestion that perhaps should liaise with psychiatric hospital if it is possible to have help desk where the other hospital can link to. If you see what is happening in other pharmacy in the hospital, you find that there are so many mental health issues that are actually going unnoticed. You just come, the drug is given to you and you dispense. At times, the issue ought to go beyond that. But because the pharmacists in the other hospital, actually probably like pharmacist Chinwe said, have not addressed themselves enough with the mental drugs, they may not be able to see that this issue at hand is not what the doctor has actually said, perhaps could be looked into in another way. So if it is either possible to have a small desk within the various hospitals, or we link to the psychiatric hospital having a help desk pharmacist that can always answer to our call whenever we call them. And my question is this: aside the antidepressant drug that you have mentioned, there are some drugs that we also know, like you said, that actually affect the cytochrome P450. And they also go to also affect, called this serotonin syndrome. There are some food which are also expected that you have mentioned, especially the steroid-induced technology food that we have gotten into. So how do we tackle such area? Because at times, it may not really be the issue of drug-drug interaction. It could be the food the patient actually is involved. We also know that today, at times what we take is steroid and not even food. If you can get the egg and the chicken within 24 hours, then you begin to wonder, are you actually eating the chicken or you are eating the drugs? So I really also want you to throw more light on the issue of the food vis-a-vis the excess. Thank you.
Yeah, thank you so much, Mr. Suleiman. Well, for serotonin syndrome, the diet or the herbs, I didn't mention that. We have nutmeg and ginseng. They've been shown to have drug, what we call it drug herb or drug food interaction, and actually cause serotonin syndrome. We don't have St. John's wort here. That also, we have also causes serotonin. If it's used with other medications that act on the nervous receptors. So those are the two, well, three of them. I'm sure we have not medication. So we should be careful when we prescribe such medication and tell the patient any diet supplements. Thank you.
I call on Dr. Yusuf Madu to unmute himself and make his contribution. Our chairman, you're welcome.
Okay, now good evening, and every other person. I hope you can hear me, please.
Yes, we can hear you. Please speak on. We can hear you.
Okay, I want to thank the presenter from Oyinlade for a wonderful presentation. Though I have been breezing in and out, I also want to thank my boss, Dr. Lolo Ojo, who is with us this evening. I also thank Professor Bola Oyawola also, and even Dr. Ademola from somewhere in another country also. I want to thank everybody. We are all working for our profession, trying to do our best to ensure that we have a better pharmacy practice in our country, at least something comparable to what we observe in more advanced nations. I'm happy to say because many of our senior colleagues have been calling on me and telling me that they are very happy with what we have been doing, especially in the area of refreshing our brains. Sorry, I hope you're still with me.
Yes, sir.
Can you hear me, please?
Yes,
Yes,
can hear you, please. Can hear you clear and loud.
Okay, so many of our senior colleagues they have been calling and encouraging us and now advising that it's not only these lectures and whatever, but also moving to the bedside. And that also raises the issue of specialization. I know my chairman, my boss, Dr. Lolojo, recently spoke to me on that. Actually, pharmaceutical care in the intervention at the bedside and all the roles of the pharmacists are some of the driving forces that made some of us to say, okay, we are coming up with this association. But luckily for me, it's as if the Lord is on our side and He's doing a lot of job. Even sometimes before we move into doing some things, we see that God is even preparing the way already. I was in a meeting last weekend, and tomorrow again I'll be in that meeting where I happen already. The happen chairman spoke to me. They are already working on this with a lot of HODs and the rest of them in the country. The specialization and whatever. In fact, we are preparing a position paper. I think it will be ready tomorrow. And we are moving to PCN. We are giving it to PCN. The areas of specialization are all these things are being discussed deeply, and they also want my inputs. So I've already prepared it, and by tomorrow I shall present it to them. So I want to say, let us keep on keeping on. Let us keep on working. And by the grace of God, I believe that it won't take too long before we start reaping the fruits of our labor in this direction. Thank you very much.
Thank you, our able chairman. That's very fun. I'd like to call on Dr. Olufunto. Dr. Olufunto, you can unmute yourself. Your contribution. Dr. Olufunto, you have something. Dr. Olufunto, please.
Okay.
You have the floor.
Good evening. Well, I didn't even know that my hand was raised. Sorry, it's not Dr. Olufunto. It's Pharmacist Olufunto. Yes, I just want to commend the presenter. She did an awesome job. It was very clear that she understood the topic very well, and I believe probably we need to think of other maybe another time to bring her again, or any other person from psychiatric hospital. Like somebody was talking about being able to access the pharmacists that are specialized. I think if we could come up with a directory with phone numbers so that it will be easy for people to be able to access the pharmacists in these areas. We have a community pharmacist that usually sometimes when she has patients who have psychiatric issues, she calls some of us in psychiatric hospitals to help her resolve the problem. So there's like a connection between those of us who work in psychiatric hospital and that particular community pharmacist. So it's like, and that's because she knows somebody. So if we have that kind of like a directory or something that even those in community practice, so that we can be able to connect and help out, because like the presenter said, some of them will go to the community practice or go to either another health facility where they had, because they have comorbid indications, you know. So we could do something like that, maybe come up with a directory that we can use. That's my suggestion. But thank you very much for the beautiful presentation.
Thank you.
How much should be, Amalara? You have the floor, please. How much should be? You raise your hand. You have the floor. Pharmacist Omalara, or mute yourself and make your contribution. Yeah? Okay, I don't know why she cannot do that. Pharmacist Omalara, mute yourself and make contribution. Maybe in the absence of further comment and contribution, I would like to call on Dr. Joseph Madu to give the closing remark. Dr. Joseph Madu, you have the floor.
Can I make another comment?
Please, you have the floor. You can go ahead, man. Go ahead.
Can I make another comment, please? I hope Dr. Madu is there. I can see we all, or personally, I enjoyed the lecture because we are doing it on Zoom. The lectures we do on WhatsApp, it's not easy to follow those lectures. But when you have it on Zoom, you can see the outline and everything instead of, you know, trying to scroll your phone to get at the lectures. I will suggest that we really make use of Zoom because it is available. Some people are saying that network connection, be it Zoom, be it WhatsApp, be it Telegrams or whatever, they all depend on the network. So for me personally, I like it on Zoom. That is just my suggestion and my comment.
Thank you. Can I speak now?
Yes, you can. You have the floor, Chairman. Carry on.
But we are using that actually. Hello, Dr. Bello.
Yes, we can hear you. You have the floor.
Yes,
please go ahead.
I hear you.
You have network problem.
Can you hear me now?
I'm managing to hear you, but you can go on. Go on.
I was just asking a question whether you are saying I should give the closing remarks.
Yes. Yes.
Okay. Let me thank everyone for coming to this meeting. I want to thank the last speaker who spoke about using Zoom meetings. We will try our best to use Zoom, but I will, like they said, one man's meat is another man's poison. I want to say this, a colleague was saying recently that she even herself not to be joining this Zoom meeting because of her data. After using Zoom all the time, Zoom meeting. So she was just tired and she stopped Zoom. I also discovered recently that while we were in Zoom meeting, some of our members that additionally, whenever we are on WhatsApp, they always I discovered that they were not in the Zoom meeting. When I went to other platforms, as I just cross-checked, I saw them making and other things there. So I don't know. Some people don't like Zoom and others like. For me, I like anyone. So I think we'll still do our best. And sometimes too, when we ask some states to use Zoom, they said no, they want to use WhatsApp. So, and we cannot force them to do Zoom presentation. Then I hope you're still with me.
Yes, sir.
Yes. I also want to thank the Pharmacist Olude or so, who was suggesting that we should have a directory of pharmacists in specialized areas. I think that's a very wonderful suggestion. It's something I'm taking away this evening. I know some of us that are specialized, and I keep telling colleagues, I have the idea of people attaching their specialized in this and that, because we are aware, know that there are two ways of specialization, either through skills. Of course, it may be one way, but then some persons are certified, while others are not. And we are also aware that we are aware that even associations can certify people. I remember when I did my course in CPR, BLS, it was by American Heart Association. So I believe that CPAN with our regulators, PCN and the rest of them, we can, in the nearest future, we can certify people. And panels, and actually that's why we have this pool of experts. So we are going to work on all these things. But for now, our colleagues that different hospitals, I'm aware of them that trained abroad, and they are already specialists in critical care and areas like pharmacy and most of them. There are lots of them in CPAN. So we shall have a directory of that. It will help us and those in the country so that we know how to follow these things. I want to thank everyone for coming on board for this meeting, because without you, it wouldn't have success. I want to thank Bello, who is always there for us, moderating the Zoom meetings, and every other person, the presenter, my boss, Dr. Joe, Professor Olaiwola, and the rest of them. I want to say thank you to all of you. Remain blessed.
Thank you, Dr. Servando Ashama. I want to call on Dr. Timmy to give us the closing remark. Closing prayer. Dr. Timmy, you have your hand. You have the floor. Closing prayer.
Yeah.
Dr. Timmy.
Yes. Before the prayer, I just want to thank the presenter also. Thank you very much, and also want to throw a little light concerning this Zoom meeting. Somebody complained about liking this Zoom meeting more than the WhatsApp meeting, and just like the chairman already said, one man's meat is another man's poison. We've had situation where we talk to other chairman of different states CPAN, when they will be insisting that it has to be the either Zoom or WhatsApp. So it also actually depends on us. It depends on what the majority wants. So want to thank everybody for actually coming on board today. So let's just close up with our words of prayer. Our Lord, we thank you for making it possible for us to actually gather here this evening. We thank you for having this wonderful presentation this night. Father, we thank you as we go and sleep. Please protect us, guide us, be with us. We ask you all these things in Jesus' name we pray. Amen.